Great. Well, again, you've heard a little bit, certainly about biomedical engineering, and Dr. Podolsky gave a little preamble to what we're going to talk about tonight. So we're just going to jump right in here. I'm going to jump in with introductions. On my far left here, Dr. James de Lemos is a professor of internal medicine, chief of the Division of Cardiology, and the Sweetheart Ball Kern Wildenthal Distinguished Chair in Cardiology at UT Southwestern. Dr. de Lemos' clinical research focuses on early detection, risk assessment, and management of cardiovascular disease, with a particular interest in the role of cardiovascular biomarkers. Next to Dr. de Lemos is Dr. Kareem. Azab is an associate professor in the Department of Biomedical Engineering at UT Southwestern and an expert in nanomedicine, drug chemistry, and cancer biology. Dr. Azab is using his diverse expertise to develop innovative cancer treatments that incorporate advances in bioengineering methods. And last but not least, directly next to me is Dr. Elizabeth Moody Davenport. She's an assistant professor in the Department of Radiology and in UT Southwestern's Advanced Imaging Research Center. She serves as the technical director for the MEG, Center for Excellence at UT Southwestern. Her research efforts focus on using non-invasive MEG in imaging to develop biomarkers for concussion, dementia, and epilepsy. So that's our fantastic talent that we have here for you this evening. I'm going to start with you, Dr. Davenport. We've sort of heard a little bit this evening about the devastating effects of Alzheimer's, which it can have on individuals and families, as well as how new therapies may drastically and dramatically change the course of the disease in the future. What role do engineering approaches play in this therapeutic revolution?
I mean, thank you, by the way. It's truly a team science approach. So there have been engineers developing the new drugs that are available for Alzheimer's disease, like lecanemab, I think maybe a lot of us have heard of. And one of the great things that I'm involved in is imaging and detecting Alzheimer's disease. So right now, Dr. Diamond is here, so I'm a little embarrassed to try and explain this, but so there's these proteins in the brain, and the lecanemab, these drugs come in and eat the bad proteins, and then I'll get a lecture later from Dr. Diamond about what actually happens on the molecular level. But it's so what these drugs are doing is they're coming in and taking out the bad proteins in the brain, and what PET imaging can do is it can go in and it can image them. It can take a picture of them. It labels them. The hard thing with PET is that it's invasive in that you have to inject a radio tracer, and it also involves radiation for the CT scan, which is great. It's very good technology. But then MEG, we've actually been able to find this very ornate signature of Alzheimer's disease really, really early in the stages. But as soon as mild cognitive impairment, we'll start seeing the signature come through. And I forgot to explain what MEG is.
Just going to ask.
Magnetoencephalography is a brain imaging technique that is a combination of fMRI and EEG. And what it does is it has 306 sensors, and it measures the brain waves. And what we can do is we can take those brain waves and project them back into the brain, see what's going on at each individual millimeter in the brain, and see how it's functioning and if it's functioning well or not. And so, and by signature, what I mean is spatial as well as temporal. We get this very lovely and unique signature that means that there are these proteins existing in the brain, and we can do all of that with a machine that's completely non-invasive, it's completely passive. Ideally, what you would come in and do is do a 5-minute scan. All you would have to do is fix your hair on the way to work. It's a little helmet, and it's FDA approved for children and babies, so it's completely safe.
And so how do you envision it playing out for family members, someone that has Alzheimer's? What does it really feel like for that family and that patient?
So what I want it for is actually for my dad and my aunt. So my grandmother died of Alzheimer's. The first grant that I submitted and got, I submitted on the day that she passed away from Alzheimer's. And we knew it, my whole lab knew it as Grammy's grant. And so we were using it to better detect it. And I keep telling my dad, I'm like, you hate, I've heard about the colonoscopies. What if you could just go in and get a quick brain scan, 5 minutes, and you would be able to detect these signatures earlier. And so that Dr. Diamond's work can be applied earlier. These drugs can be administered even before you're really noticing symptoms and before your life is impacted. That's my goal.
That's great. It's fantastic. Dr. Azab, I'll turn to you. You specialize in cancer care. There have been incredible advances, even some cures, and yet cancer treatment can be notoriously brutal on the body. How does your work leverage existing treatments to improve the efficacy while reducing the negative impact?
Thank you. Actually, we never had a problem with cancer therapy being not efficacious. Actually, it's probably too efficacious. It hits cancer cells, but it also hits normal tissues of the body, which limits our ability to give more treatment. And that way we don't get to treat the cancer cells because we are worried for the effects on the normal cells. So what we have thought in a way that I want to maybe call it simplistic, how nobody thought about that before. It's if we have a localized tumor, say in the brain or in the breast or in the cervix, that didn't metastasize yet, it didn't spread yet. Why we need to come and give an injection that goes to the body, to the whole body, and affect the whole body, while just a small fraction of the treatment will actually get to the tumor? So the idea was that we developed a jelly-like material that when the surgeons go in and take out the tumor, or in places that there's a natural cavity like the canal of the cervix, we will go inside and inject that gel to fill that cavity and release the drug, the chemotherapy, from inside out. So now our highest therapy is actually in the cancer tissue. We got almost 1,000-fold of therapy in the tumor cells and almost 100-fold slower everywhere else in the body. So we kind of improved what we call the therapeutic index, like the therapy versus side effects, in about 10,000 times. We think that there's absolutely no reason to treat the whole body if we can treat locally.
Well, so what if the cancer spread already?
So in that case, we cannot treat locally, of course. In that case, we want our chemotherapies or treatment, wherever they are, to get to the cancer region specifically. And the way we do that, we do it with what we call nanotherapy, with nanoparticles. Now, nanoparticles, just to give you an idea, if you put about 1 million of them in a line, in a straight line, they make about the thickness of a human hair. So these are very, very small particles that we fill up with therapy. Not only, we put on their surface kind of detectors that can identify the cancer cells, like antibodies to specific antigens or proteins on the surface of cancer. So that way, these packages, if you want to think about them, they will go stick to the cancer cells, deliver the package, and spare the normal tissues because they don't stick to the normal tissues. They just stick to the cancer areas.
Phenomenal. We've heard a lot about immunotherapy, and we've heard a little bit about it earlier tonight. Does this technology, nanotechnology, work in concert?
Definitely. So immunotherapy, just tell you what's that. Actually, it's bringing our own immune system to fight cancer. As a principle, our bodies always generate cancer cells, but our immune system is right there to take care of them all the time. And when some of these escape the immune surveillance, they become tumors. Now, immunotherapy is teaching the immune cells again that these are the bad guys. And the way we do it, we literally load these nanoparticles with cancer antigens, and we send them to the immune cells now this time. We tell them, hey, learn. These are the bad guys. Now, if you meet these anywhere else in the body, go ahead and fight them.
That's phenomenal. So, we've heard a little bit about, brain. We've heard a little bit about cancer. As a practicing physician, cardiologist, I'm curious, how has bioengineering impacted your practice of medicine, Dr. De Lemos?
Well, thanks, Marc. I think when I look back over my career and think back to when I was training and practicing now, the impact of biomedical engineering has been breathtaking. If you think about, for example, the aortic valve, this is the valve that connects the heart with the main blood tube, the aorta in the body. And when people get older, that may wear out. It can calcify and get narrowed. And that's an operation that's typically done in people in their 70s or 80s, required general anesthesia, a long recovery, high morbidity, and some patients died in that operation. And you think today that through advances in biomedical engineering, it's now possible to replace that valve with a catheter procedure. People can come in, the procedure can be done with conscious sedation. They don't even have to go on a breathing machine or have full anesthesia. The valve can be replaced through a catheter, and that valve, it's obviously the operation is easier and safer, but it's also a better valve based on the engineering advances. It's a larger valve, and all the evidence suggests that it's more durable. It's completely changed the practice of treatment of aortic valve disease and become the preferred method of just a breathtaking advance. If you think about electrical problems with the heart, arrhythmias, we now have devices that we implant to monitor rhythms, but also to treat them, pacemakers and defibrillators that can restore the normal heart rhythm when it goes into chaos. But the computing power in these devices is what a Cray supercomputer would have had 20 years ago. These devices have artificial intelligence technologies that can detect rhythm abnormalities and report those through Bluetooth to physicians or care providers and feed that back so that we can intervene on patients. Think about your Apple Watch that many of you will have in the room. Engineering advances with the Apple Watch and algorithms that engineers have developed allow them to detect atrial fibrillation, which is the most common electrical rhythm of the heart, and puts people at risk for stroke by algorithms on their iWatch. So they can get an alert that people will then be able to feed back to their physicians, or if we can improve the care processes around this technology, feedback automatically, and allow us to intervene and put people on anticoagulant medications to prevent the stroke that so often we've missed in the past because the AFib is not diagnosed until people present with their strokes.
Well, it's clear bioengineering has the ability to help with prediction and prevention. What about someone coming in with an urgent issue, heart condition, immediately into the hospital?
Well, one great example is the blood test that we use to diagnose a heart attack. It's called troponin. It's a test that it's a protein that's released from the heart when it's damaged. And if you go to the hospital with chest pain, the doctors will order troponin levels to make the diagnosis of a heart attack because it's released in the blood. But chemical engineers have developed advanced technologies to allow a much more sensitive detection of troponin, so we can detect levels that are 1,000-fold lower than we could have detected 10 or 15 years ago. And that's led us at UT Southwestern to develop new pathways for treating patients with chest pain in the emergency department. We were the first hospitals in the US to introduce what they call high sensitivity troponin assays. They allow the detection and what we call ruling out of a heart attack in an hour or two, so we can really move people much more efficiently and safely through the emergency room. And our research group has capitalized on that engineering advance to ask new questions. If you can detect tiny levels of this heart damage protein in the blood with a heart attack, what might you find if you measure the troponin in people like us? And it turns out that people who appear to be healthy but who are at risk for future development of heart problems, particularly congestive heart failure, have very small but measurable levels with this a new high sensitivity troponin, and we've been able to use that to predict who's developing heart attacks and hopefully, I should say, heart failure in the future, and allow us potentially to intervene earlier so that we can prevent that.
Got to be careful because you'll have a line for that test tomorrow.
We're open for business.
In the office. Dr. Davenport, to you, a similar question, but, related to the brain, sort of clearly diagnoses, bioengineering helps with that, even treatment. Just curious, what are you most excited about in terms of the future?
Gosh, there's so many things. So I'm a computer programmer, so I do devices, but I also do the software that makes the pretty pictures that the radiologists read. And there's so much math and science behind that we need good engineering for. And then once you're able to get that diagnosis, there's responsive neurostimulators and all these different neurostimulators that are very much like the pacemakers that Dr. Lemos talked about. Except they go into the brain and they can detect seizure-like activity and respond with an equal and opposite activity so that they can actually stop these folks from having seizures. And there's transcranial magnetic stimulation, which is another, it almost looks like witchcraft to me a little bit. It's this kind of figure 8 thing that you hold over their head, but it's been very good at treating treatment-resistant, pharmacological-resistant OCD. And you go in for a couple of different treatments, and it's very helped people very much. And then lastly, there's this really cool technology at UT Southwestern that one of my friends runs, Dr. Bhavya Shah, called the HIFU, High Intensity Focused Ultrasound, which is just kind of magical. It uses ultrasound. It has all these tiny little ultrasound probes, and like the Meg has all these tiny little sensors around the machine that I use to listen to the brain. What it can do is it can send a signal into the brain, and much like you would have a magnifying glass in the sun, it can magnify those ultrasound waves onto a tiny little millimeter spot and break up a tremor network, for example. So my mom has Parkinson's, and she's actually a candidate for this procedure where she could have the HIFU, and the worst part about it is she would have to shave her head. But she's thinking about going gray anyway, so it might be okay.
Just listening to that, for some of the other work I do for the institution, we've been working on a new, sort of tagline, and I think, we just hit it. It's not science fiction, it's UT Southwestern.
Oh,
It's pretty amazing. Well, that could work too. It's just magic. Yeah. Dr. Azab, when we think about cancer, actually, when we think about any research, that timeline from bench to bedside is really, really long, a decade or more oftentimes. What's happening in your lab that can speed up that process from, what's happening in the lab directly to the patient?
So we have another science fiction. We actually try to provide better tumor models, better cancer models to mimic what's happening in the patient. Because right now, unfortunately, many times we develop amazing drugs in the lab. They work beautifully in the Petri dish. We go to the patient and the success rate is not as good. And there are many reasons for that. The most important out of all of them is the tremendous heterogeneity in the patients and our limited number of cell lines that we work with. And the way that we work in a Petri dish on plastic, that's not anything close to what the tumor really looks in the patient. So recently in my lab, we have developed something that we called 3D tissue engineered bone marrow that actually we take a tumor biopsy from patients with blood cancers from the bone marrow, and we tissue engineer them in the lab to look pretty much similar in the shape, in the 3D structure, and in the cellular content, not only the cancer cells alone, but we take the whole bone marrow and we engineer it to look like what the tumor looked in the patient. And from one aspirate, we can make almost 100 replicates of the patient. Now we can try on that patient, outside the patient, 10 different drugs. And instead of treating that patient with a protocol that, if he had that stage, that level of cancer, you treat with 1, 2, 3, I want to change that. I want to change the protocol, if you want to think about it that way. I want every patient, every individual to come, build his tumor outside the body, try a bunch of therapies on it, and tell the oncologist, look, drug number 1 and 4 and 9 worked perfect for that patient. So don't go with the protocol. We want to use these specific therapies for this specific patient. We want to personalize the treatment to be per patient.
That's phenomenal. And that's for existing known treatments. What about a similar process, or how do you leverage that concept, if you will, for actually creating new treatments?
Indeed. So as a principal, we work very closely with pharmaceutical industry right now, because we can do what we call ex vivo clinical trials. It means before we jump to a $10 million clinical trial, we can now take the new drug that the pharmaceutical company is developing, and we can test it on 20, 30, 40 patients outside the patient. Now, luckily, we have data that our model predicts about 90% of the clinical responses in the patients. So in a way, we are saving a lot of money and a lot of time and a lot of patient health trying drugs with trial and error.
It's phenomenal. It's phenomenal work. Now, Dr. Lemos, let me turn back to you. You told us a little bit about where we are and how bioengineering has impacted practice today. What are you most excited about for the future of biomedical engineering in heart care?
Yeah, we have the same aims that Kareem has in cardiovascular medicine to personalize prevention and treatment. But we have a disadvantage because we don't have access to tissue, and we don't do biopsies for most cardiovascular diseases. So we have to think of other ways to get the same kind of information that's individualized so that we can personalize the approaches to prevention and treatment. And that's been a major focus of what we've been doing over the last 20 years in the Dallas Heart Study is pulling together disparate information from genetics and blood-based biomarkers and, really importantly, imaging to try to come up with different portfolios of things that would predict different potential cardiovascular diseases in the future. And we've made a lot of progress there. We're headed in the right direction. But I think part of the future is to capitalize on the information that we're already collecting in routine clinical care. And one of the areas I'm most excited about is the ability now to capture information. Take, for example, the CT scan that many of you have had that's been done for a specific purpose. Do you have a pulmonary embolus, or do you have a problem with your intestines? But there's a whole host of information, some of which we don't look for purposefully, and others we might not even know what to look for, that artificial intelligence can pull out of these images. And we've got groups now working, for example, on capturing really relevant information from scans that were done for clinical purposes. For example, it's possible with completely automated means and artificial intelligence to determine how much fat you have in the liver from any CT scan that's done. And that fatty liver is the most common cause of cirrhosis and liver cancer right now. We're interested in plaque in the heart arteries. A CAT scan of the chest that's done for any purpose can be exploited to capture whether they have plaque in the heart arteries. And if we can get sophisticated about how to feed that information to patients and doctors, we can intervene, for example, and start somebody who had a chest CT scan because they had a cold or pneumonia and has plaque in their arteries, get a note to the doctor and the patient without ever, all electronically, so that they might start a statin, for example.
Yeah, that's great. What about, what's the potential for leveraging, again, biomedical engineering sort of post an event, post heart attack? What are the opportunities that you envision?
Yeah,
treatment for post.
Yeah, I think imaging will be really important, and Dr. Zaman who's a new member of the faculty in the Department of Biomedical Engineering, for example, is working on sensors, and she's developed techniques to measure heat with sensors in the arteries and in the heart itself. And when the heart gets inflamed, and inflammation is a major determinant of when these plaques develop, and particularly when they break open and cause heart attacks, and also in the heart after a heart attack. And she's developed temperature probes that can be either put on a catheter or measured with external means to allow us to determine inflammation through imaging methods that can localize it either to the artery or to the heart itself.
Well, I hope all of you in the audience can appreciate that all of these innovations wouldn't be possible without all of your support and the foundation's support. And the future is bright, as you can tell. And that's because of all of you. We couldn't be here. We couldn't be doing this. Our fantastic faculty couldn't be doing this great work without your continued support. So I want to say thank you for this. Thank you for all you've done. Thank you for the work that you will continue to do. And thank you for a great evening.